One of the most important clinical trials that will be presented today in the presidential session is the results of the phase 3 trial in the adjuvant setting of melanoma patients with the ipilimumab of 10 milligrams per kilograms versus placebo. Probably you know that the first endpoint of this study was reached years ago, and the first endpoint was relapse-free survival and was positive in the study years ago. Today we'll be discussing the overall survival that you know is the most important endpoint in the adjuvant setting. You remember that at the time of the first release, with a median follow-up of 2.3 months, the relapse-free survival was better with an hazard ratio of 0.76%. Now, the overall survival showed an hazard ratio of 0.72%. This means a 28% of reduction of risk for death of the patients treated with ipilimumab. This is an important news, and also at 5 years, there is an 11% of patients alive more than the control arm. This, of course, is important because now, from the advanced setting, the checkpoint inhibitor treatment in melanoma, and I think not only melanoma in the future, will be for the patients with adjuvant disease, where we have just a high risk, no evidence of metastasis, but we can reduce, of course, the mortality and the relapse. So this is, at the moment, one of the most important findings of this ESMO in another field of melanoma, the adjuvant setting, and this will be probably a game changer. Another interesting clinical trial that we'll be discussing this afternoon in the melanoma oral presentation session will be the 169 study. This is a study that enrolled patients in 2012, and this was a study which compared the ipilimumab at 10 milligrams per kilograms versus 3 milligrams per kilogram. You know that ipilimumab is approved now in the treatment of advanced melanoma at dosage of 3 milligrams per kilograms, but ipilimumab showed important results not only at this dosage but also at other dosage of 10 milligrams per kilograms. Although the 3 milligrams per kilogram is the approved dosage, in a phase 2 trial, the 10 milligrams per kilogram showed better overall survival, slightly better overall survival than 3 milligrams per kilograms, and this is one of the reasons because this trial compared the 10 versus 3. The overall survival was the primary endpoint, and the study showed a superiority of EP10 versus the EP3, and this was surprised, but this is consistent because the impact of EP10 at 1, 2, and 3 years, it's always better in the patients treated with EP10, and at 3 years, the overall survival rates of the EP10 was 31% versus 23% of the EP3. This is really interesting data because confirm the higher value of EP10. The hazard ratio was 0.84. This means a 60% of reduction of the risk for death. And as expected, ipilimumab did not show an impact, a different impact on progression-free survival and objective response rate, the surrogate endpoint, but just in overall survival. Of course, the EP10 was more toxic than the EP3. The percentage of patients who discontinued treatment is 31% in the EP10, 90% in the EP3. But of course, the impact on overall survival will make this option an important option. This option will be important probably not in first line, where we have at the moment other more powerful treatment like the combination of ipilimumab and nivolumab over the BRAF plus MEK combination, but this may be an option in the future for the patients, for the resistant patients, the patients who failed, for instance, the PD-1 treatment. This could increase the outcome of these patients and giving them a benefit in terms of overall survival.